Welcome everybody to live from Cleveland Clinic. We have obesity management and IBD as our session today. And we're excited. We have over 600 providers registered from over 70 countries. I always like looking at the map and seeing how far away people are. Thank you also to our sponsors, Cook Medical, Janssen Biotech, Medtronic, and Olympus for their support. Of course, I'd like to introduce our wonderful faculty. Course co-directors, Dr. Norma Atkinson, a wonderful obesity medicine physician, and then Dr. Florian Reeder, who I imagine many of you already know from other live sessions. He is the vice chair of the Department of Gastroenterology, the co-section head of inflammatory bowel diseases, and the director for the Program for Global Translational Inflammatory Bowel Disease. And then we have some amazing speakers and panelists for you today. We have Dr. Butch, who's the Director of Obesity Medicine in the Bariatric and Metabolic Institute at the Cleveland Clinic. And I discovered also the first physician in the US to complete subspecialty fellowship in obesity medicine, which is pretty exciting. We also have Dr. Fang, one of our bariatric foregut and general surgeons here at the Cleveland Clinic. My colleague, Dr. Manny Braga Netu, who is an expert in IBD and in pouches. And then our case today will be presented by Dr. Joseph Slyman, our current IBD fellow and soon to be IBD faculty with us. So with that, I will turn it over to Dr. Atkinson, who's going to introduce us to the IBD Obesity Clinic.
So today I will be talking about management of obesity and IBD. Okay, so some definitions. Obesity is a complex disease, it's a chronic relapsing and treatable disease, and it's multifactorial, and it requires an individualized approach. Overall, the prevalence of obesity globally is estimated at 16.8%, and the US about 42%. And the prevalence among obesity among patients with IBD is between 20 to 40%. Here we can see on the left side, based on a retrospective study with 581 individuals, the prevalence of obesity among IBD was estimated at 32%, slightly higher among patients with UC than Crohn's disease. And to the right, we see the prevalence of obesity worldwide, and in the US, as I mentioned, in the US about 42% and globally 16.8%. The complications of obesity beyond common conditions like heart disease, we can find obesity related to inflammation and immunological diseases, but overall more than 200 conditions have been related to obesity. That's why it's so important to treat it seriously. The physiology of obesity include homeostatic pathway, which will regulate the food intake and energy expenditure. This is controlled in the hypothalamus and receive input from different organs, including the stomach, the gut, and the pancreas, and the adipose tissue. The hedonic pathway is a rewards-based regulation. There are other factors that also play a role in the physiology of obesity. Adipose tissue, it has an active role in inflammation. Hypertrophic adipose tissue will decrease the oxygen diffusion from the capillaries, and this will trigger a cascade of signals that will increase the inflammation and eventually cellular damage. We know that adipose tissue secretes multiple adipokines and hormones, and also interleukins, cholesterol transport, and other substances that eventually can cause immune cell attraction, inflammation, and wound healing. Obesity and IBD, we think there's two relationship between obesity, inflammation, and gut microbiome. The cornerstone of obesity include increased adipose tissue, hypertrophy, and increased subcutaneous and visceral fat, also insulin resistance, and changes in the microbiome. All these will cause low-grade chronic inflammation, along with changes in the environmental factors and other inflammatory substances may be related in the development of IBD. Why is it important to treat obesity in IBD patients? Well, there's an increased risk of related visceral adipose tissue, including other metabolic diseases, cancer, and inflammatory conditions. And obesity may cause changes in IBD therapy by increasing drugs clearance, leading to shorter half-life and low drug concentration. Also, the obesity may increase the risk of hospitalization and postoperative IBD surgeries. Assessing obesity in IBD is a challenge. Should we use a BMI or should we use visceral adipose tissue? And the studies are limited and not conclusive. And Crohn's disease, the studies suggest that overall obesity by BMI is not consistently associated with increased prevalence of IBD-related complications. However, in a retrospective study, it was shown increased mass fat index among patients with some type of phenotypes in Crohn's disease. Here we can see a retrospective study of 50 patients with Crohn's disease, and they look at the mass fat index, which is the ratio of visceral to subcutaneous fat. Among these patient participants, they found out that patients with complicated Crohn's disease will have increased visceral fat compared to subcutaneous fat in complicated versus inflammatory. They also found out that the patients have longer duration of the disease and higher CRP levels. Here in the graph to the right, we can see the phenotype. Penetrating and stricturing Crohn's disease were related to higher mass fat index compared to inflammatory only or stricturing and penetrating disease. We look also to IBD and obesity, maybe increased hospitalizations and days and cost of hospitalizations. In this retrospective study, they look at the numbers of days spent in the hospital. For Crohn's disease, patients with obesity spent more time than patients without obesity. And for patients with ulcerative colitis, it was similar results. When we look at the type of hospitalization, those with medical management and obesity spend also more time compared to those without obesity. Same with surgical admissions. So overall, this retrospective study shows that the median numbers of days were 8 versus 5 in those without obesity. And also the cost of the hospitalization was significantly higher among those with obesity compared to non-obesity. So the proposed model in recent studies is there's limited and inconclusive studies about obesity and IBD. However, it seems there's a relationship between these two conditions and because barrier dysfunction, bacterial translocation, changes in the gut, and inflammatory adipokines. So this relationship may affect the phenotype, the natural history of the disease, and also the surgical management. So the proposed models is targeting obesity as the adjuvantive therapy and optimize weight prior to elective surgeries. Bariatric surgery seems to be beneficial in some patients. We'll talk a little bit more about this. So the goal of treating patients with obesity and IBD patients is to look for patients at high risk with a BMI of 30 or 27 with correlated comorbidities. Integrate IBD and obesity guidelines, and promote healthy lifestyle among these people, these patients, and perform clinical and basic research related to IBD and obesity. So there's a need for multidisciplinary team, multidisciplinary obesity care, where we can take care of these patients seriously. The foundation, of course, the excellence in IBD care, and then refer these some patients to obesity medicine, those that meet the criteria to be treated with a BMI of 30 or greater, or 27 with comorbidities. And in some selected patients with a BMI of greater than 35, and maybe candidates for bariatric surgery. However, to treat these patients seriously, we require a multidisciplinary team with GI, colorectal surgery, obesity medicine, bariatric surgery, nutrition, behavioral health, sleep medicine, and fitness and wellness. So we are taking care of obesity very seriously, and we work in this multidisciplinary team and refer the patients accordingly. Taking obesity seriously for obesity medicine, we have a very systematic way to assess this patient, evaluate and assess this patient. Take a very detailed past medical history, weight history, including dietary recalls, sleeping behaviors, eating disorders, medications. In terms of physical exam, it is very important to do waist circumference and Edmonton stage, in addition to the BMI. Nutritional status is particularly important in this population because we want to prevent sarcopenia or vitamin deficiencies that sometimes can be masked and obesity or overseen. So we do labs, vitamin, again, waist circumference and body composition. The assessment and plan can vary, depends on patient's preference and medical recommendation. Can be only behavioral with dietitian and behavioral health, or we can add medication, and in some patients refer to bariatric surgery. Different ways, again, to assess obesity in this population. Very easy is the body mass index, and based on this metric, classify the patient as a normal weight, overweight, or obesity. However, we know that visceral adiposity may be more active role in complications related to IBD and other inflammatory conditions. So we recommend to do waist circumference and percentage of fat by body composition. Here are the cutoffs. The cutoffs can vary based on ethnicity, but in general, male more than 40 inches will meet the criteria for obesity, or females more than 35 inches, and a BMI of more than 30. So the goals of medical treatment is treat obesity as a complex disease, facilitate the management of eating behavior, slow progression of weight gain or regain, improve the overall health and quality of life, and with medications or bariatric surgery in some patients. So the initial goal is to have a total body weight of 5 to 10%. That's enough to start experiencing some improvement in medical condition. In this article published in 2022, we can see that with the use of semaglutide 2.4, diabetes prevention started improving with only 5%, 5 to 10% total body weight. Physical function started improving that 5% total body weight and continues throughout the weight loss journey. Hyperglycemia or type 2 hyperglycemia started improving with 5% and up to 20%. cardiovascular risk reduction start improving with 10% total body weight and continues throughout. But hypertension, a common disease, start improving with only 5% total body weight. Of course, the greater the weight loss, the better the improvement. But sometimes you don't need to lose a lot of weight to start experiencing some health benefits. Sleep apnea, about 7%. Remission of type 2 diabetes, 10% to 30%, and NASH or muscle now, 10% start improving. So there is an opportunity for innovation, research, and development. The way we see and conceptualize this is the IBD Obesity Clinic. It's an opportunity to develop more RCTs, create a biobank and global database. As I mentioned at the beginning, there's very limited data and conflicted more retrospective studies than RCTs that can give us more information about the relationship between obesity and IBD patients, which might be a little bit different between Crohn's disease and UC. Take-home messages: obesity is a complex disease that requires chronic treatment, affect the adipose tissue, inflammation, and gut microbiome. It might be important to assess obesity in IBD patients by measuring visceral adiposity, either waist circumference or body composition, in addition to the BMI. Multidisciplinary management is critical. Weight loss medication may be beneficial in some patients. Same with bariatric surgery, and need for research and innovation in this population. And that's what I have.
Thank you so much, Dr. Atkinson. What a nice intro and overview. Quick question for you. You mentioned BMI and comorbidities. Are there comorbidities that you commonly see in IBD patients specifically, or is it similar to the overall patient population?
Again, there's kind of inconclusive data. What I could review was definitely cardiometabolic related conditions like diabetes, hyperlipidemia, and also complications related to IBD. That's more conflicting data, but more related to cardiometabolic conditions.
Perfect. Thank you. And now I'm going to introduce Dr. Butch. He's going to give us a nice talk on obesity medical treatments, a field which has really exploded over the past couple of years.
Thank you for the invitation to talk a little bit about the medications used for obesity, which have been around. As you see here, medications have been used to treat obesity for the better part of a century. Certainly, these first generation drugs that we see were primarily before we really understood obesity. We thought it was a behavioral problem that we just needed to suppress the appetite of the person who has obesity. And therefore, a lot of the medications that were developed were stimulants. Certainly, some had a lot of complications, causing arrhythmias and these kind of things. But the thought still was, let's treat the appetite in the person who has got a problem with their appetite. So let's decrease the caloric intake by wiping out and suppressing the appetite. Certainly over the last 10 years, we've seen these second generation drugs, which I'll talk about shortly. And that was really with the understanding that these are medications that treat different pathways involved in a very complex pathophysiology and not really targeting hunger, though some people still do that, unfortunately. And then certainly most of you have heard about the next step of these third generation drugs, which has really started in 2021 with the FDA approval of semaglutide 2.4, which is a higher dose of a lower medication called Ozempic, and it was called Wegovy in 2021. And then the year later, Mounjaro, which was a combination of a GIP and GLP-1 receptor agonist. Again, these seem to be different because they're highly effective. But what we have in the United States currently are ones that are FDA approved, the stimulants that are still around. Phentermine, a very effective drug. Phentermine is combined with topiramate, that was called Qsymia and approved about 10 years ago. Naltrexone and bupropion, also called Contrave, and a higher dose of liraglutide, which is called Saxenda, all came around 2012, 2014. And then obviously the ones I talked about earlier. For monogenic obesity, there's actually a medication called setmelanotide, which I won't talk about tonight, which is clearly available for those who have monogenic forms of obesity. Off-label medications that are clearly used in treating obesity, as we still do. Diabetes medications like metformin, amylin agonist called pramlintide. You have various short and long-acting GLP-1 receptor agonists. Obviously, tirzepatide is talked about. SGLT inhibitors don't really cause a lot of weight loss, primarily through glucoseuria, but certainly these diabetes medications are available. Migraine medications, seizure medications, topiramate and zonisamide, the generic forms of Contrave, which are bupropion and naltrexone. Naltrexone has been used in IBD, but also used in pain, but these are higher doses, again, which I'll talk about shortly. Where do these medications work? Well, they work in the brain and the gut, primarily where we see obesity and weight regulation being pathways being developed. And so for the most part, they work in these areas. And obviously you see other obesity therapies, which will be talked about, working in the same areas. We look at all the randomized clinical trials that have been done with all the medications up to date. Before 2021, we basically had a variety of medications that I just mentioned, but the effectiveness, and this is placebo subtracted, is less than 10% of body weight. And certainly that was helpful for some, and some are really high responders, but obviously the overall mean efficacy was not that spectacular. And clearly after 2021, which caught the buzz, was 50 to 100% more effective drugs that were out there. And so obviously that has really led to not only hyper awareness, but obviously people doing a lot better and more headlines. So the medication that really started and kicked this off was called semaglutide, again, a GLP-1 receptor agonist, and really is really part of this, what we call nutrient stimulating hormone-based therapies, or NUSH therapies. And this was the step 1 trial, a 1-year trial, which produced significant amount of weight, about 15% body weight loss. You see the placebo subtracted arm there. And these are people that we generally see. People have, moderate to severe obesity and have a bunch of metabolic conditions along with it. We also, in these trials, look at categorical weight loss data. The primary before the medications that I used prior to 2021 that I showed you, for the most part, would be around 50 to 70% of the population would lose 5% body weight loss. And again, as Dr. Atkinson pointed out earlier, that 5 to 10% weight loss is pretty significant in terms of not only weight, but also other health conditions. And you see here 90 and 75% respectively, but the headline really was more than a third of the population lost more than 20% of their body weight, which clearly was impressive, and impressive enough to think about, and which you'll hear soon, numbers close to what we see in bariatric surgery. Among the side effect profiles, specifically GI side effects, were quite common in some, but what we saw individually is that people would have mild to moderate conditions of nausea, diarrhea, vomiting, constipation. These were temporary, mainly when you increase the dose, and tolerable. Tirzepatide came out a year later with the SURMOUNT-1, and you see some of the data here in that trial of similar individuals. You see categorical data, 63%, so twice as many individuals lost 20%, and 40% of the individuals in the trial lost 25% of their body weight loss. Again, looking at side effects, GI side effects were more common, as you see here, but again, mild to moderate, generally tolerated, and again, sort of fitting the class of side effects that we see. And these drugs, both in step 5, which was a 2-year trial, and the SURMOUNT extension trial, which is a 3-year trial, showed sustained weight reduction with these medications versus the placebo arms. So what was so special about this drug class versus the others, in particular because the short-acting GLP-1 receptor agonists were used, 10 years prior to that. So why were they so effective, and where do they work? So we see the peripheral action of this GLP-1 receptors. Again, the L cells in the gut produce GLP-1 hormone, which was released after being stimulated by nutrients. That travels up through vagal tones up to the brain centrally and having an effect. So that's peripheral GLP-1, which we see increase after bariatric surgery. We also see increase after these drugs. But the brain actually makes its own GLP-1, and we see in several parts of the brain making GLP-1, and that also, all of that is expressed in the hypothalamus, specifically the arcuate nucleus, and that's where you see the anorectic effect and also the weight loss effect from this class of drugs, working and activating in two neurons in the brain, the POMC, which it directly activates, and then inhibits the NPY. Again, you can think about POMC as the yin and yang of POMC, increasing energy expenditure and decreasing food intake when stimulated, and the NPY neurons decreasing energy expenditure and increasing food intake when they're stimulated. So it stimulate POMC and block or inactivate NPY. Perfect in that sense. So where do we see these effects? As you see in this diagram, the effects of these medications clearly are widespread, and we see specifically inflammation. We see effects in the kidney, in the heart. When we look at the stomach, which obviously is important in sort of our digestive tract, we see the motility issue of it slowing down the motility. And that really is probably the driver of the side effect profile that we see. And also important when we look at medications and the use of medications right before a procedure, an endoscopic procedure, bronchs, surgical procedures, where we have to probably cut back on the use. Probably 1 week prior to these procedures, we should stop the medication. And that's really because it has this effect on gastric empty. When we think about fatty liver disease and the effect of this class of drugs on the liver, there's actually no receptors in the liver. So really probably what we're seeing is the reduction in inflammation drive the benefits, the health benefits we see in fatty liver disease. What we see here is a graph of a table of just looking at why the differences between the short and long acting, and maybe probably because of the effectiveness, is the penetration of the drug into the brain. So not only the size of the molecule that the GLP-1 receptor agonist is mimicking, but also if it can penetrate the brain. And so we look at the differences of not only our native GLP-1 that we create and make from our L cells. We see early short-acting liraglutide sort of mimic this by fixing and moving around some amino acids and substitutions you see in both the short-acting exenatide and there. But what I want you to sort of pay attention to is the addition of the fatty acid moiety on semaglutide. So that was allowed it to sort of stay in the brain longer and penetrate and get across that blood-brain barrier, and therefore having a longer half-life and being more effective nonetheless. We see GLP-1 targeted in many different metabolic conditions. These slides are a little bit out of order, but we see the pinnacle study of the SELECT trial 2 years ago, which showed an improvement of a reduction of about 20% reduction in MACE in individuals who had established heart disease and were put on semaglutide 2.4. We see effects and preservation of heart failure in people who were put on semaglutide. With fatty liver disease, both semaglutide and tirzepatide have been used. You can't see this because it was blocked, but basically showing through the FLOW trial that semaglutide is effective in reducing long-term kidney effects and sort of the MACE criteria for the kidneys. were reduced about 24% with semaglutide. That's why it was approved this past January. Sleep apnea, last year a trial came out in looking at tirzepatide for moderate to severe forms of sleep apnea, showing improvement, and that was approved. And then obviously in 2023, it was approved for heart disease. So you have not only approval for diabetes and obesity, now you see this drug class have approval in different comorbidities, cardiometabolic comorbidities. And if we look at the future of emerging drug therapies, there's about 18 new drugs that, again, are working in the same area of the brain. And you see now combinations really are taking a strong interest from many different companies. And really, most of the drugs have achieved an efficacy of more than 15%. So you're already beyond the second generations. You see combination oral formulations. You see some companies looking at the intradose and extending that not only from weekly, but to monthly. And again, as I just showed, indications for other cardiometabolic conditions. And again, I could go on, but I know I only have a few minutes left. But this is just a triple therapy. So triple agonist, adding glucagon and showing even more efficacy of reaching 25%, again, 22 if you subtract placebo. And not only did 100% of the individuals in the trial reach that 5% body weight loss, but more than a quarter lost 30% of their body weight. So clearly you're seeing a class of drugs that has some effectiveness. And you see the future here, not only, and actually just to pay attention to the first row of everything really, around 15% and greater, from a higher oral dose of semaglutide, a higher injection dose from 2.4 to 7.2, the combination of CagriSema, which is an amylin agonist in semaglutide, survodutide, which is a GLP-1 glucagon dual agonist, and then what you might have heard this week, orforglipron, which is a small molecule GLP-1 receptor agonist. So the future right there is bright. For the gastroenterologists who take care of MASH in the group, this is the future there. Not only approval of semaglutide and tirzepatide for obesity, but soon those will have indications for MASH. The approval there I see in the column is the obesity approval. And you see other drugs that are looking at combinations being effective. And again, this is all in addition to Madrigal's selective thyroid beta agonist. So as pointed out earlier, to reduce disease, you have to get to 5 to 10%. If you really want to mitigate other diseases like cardiovascular disease and MASH, you have to go to about 15%. And then if you really want to make a difference in heart failure, sleep apnea, type 2 diabetes, you have to achieve about 20 to 25%. What we've been up until recently is ineffective lifestyle interventions, even though a lot of insurance plans tout those. They have been largely ineffective. Early pharmacotherapy, as I showed you, effective in some, but not in many. Endoscopic interventions are becoming more popular, but still, if you look at the data, not much more than 15%. And obviously, clearly, like you're going to hear in a few minutes, is metabolic and bariatric surgery is highly effective. Where these new drugs fit in is really in that sort of gap, not only showing effectiveness in weight and diabetes, but multiple other conditions, as I showed. And then thinking about combination therapy, we're going to achieve even greater effect if needed in individuals. So switching over to some pearls of management, just to wrap this up, we have to understand first that the patients who might come to you for IBD, when talking about their weight, it might be a very difficult conversation because many of them have bias themselves. They think obesity is not a disease and it's their responsibility. So thinking about treatment or going to a specialist might be very abnormal to them. What's come out recently is sort of this hyper focus on weight loss has actually been a little bit confusing. So we think about weight loss not only on the scale or even the BMI change, we're not accounting for the body composition changes. And so obviously, more importantly, we should be looking at muscle mass loss and fat mass loss and how to differentiate those when taking care of our patients with obesity. Many questions always come along of what to do when that effectiveness, meaning that weight loss, begins to wane and you don't see a lot of change or drop anymore. Does that reflect that you have an ineffective therapy? No, it doesn't. It means that the body is adapting, which we call metabolic adaptation, to that weight loss. And that's actually where you begin to think about a combination therapy. Many people might not be hyper responsive to certain medications. So certainly don't give up. You should continue to try. And please do not think about using compounding versions of these drugs. It really is, the wellness industry rebranding itself and selling a little bit of snake oil. So how do you choose the right IBD for your patient? How do you choose the right medication when treating obesity? There are not a lot of guidelines out there. This is the only real one that we can see of the European guidelines that had this one recommendation about obesity drugs. We don't really say anti-obesity drugs anymore, but they should be used according to their indications, which are a BMI over 27 or with a comorbidity over 30. Orlistat, which really isn't used much anymore, should be avoided. And you can see that in this table that I created. Obviously, the newer therapies are preferred. They're effective or even more effective. But again, coverage is a big issue right now for obesity care. As you see, the top three are the GLP-1 receptor agonists, liraglutide being shorter acting, so it's a daily, versus the top two, which are weekly. Phentermine, which has been around since 1959, is a very effective medication by itself. Clearly, there's people I've had on for more than a decade and a half, doing perfectly well, maintaining their weight after a significant amount of weight loss. That, when combined with topiramate, as you saw in the earlier graph, can be more effective. But again, you have to look at maybe some interactions with topiramate with other medications, but maybe something that you could entertain with generic drugs first before you go to the brand name. Same thing with naltrexone bupropion, which may have some benefit from that stimulatory aspect of bupropion. Metformin, you might think this should be a no-go from the start in terms of being worried about the GI side effect and exacerbating your IBD patients. But I have used it and it has been effective in some. So I think that should be considered, but obviously not at the top of the list. And orlistat, I don't even use anyway. So I'll spend very, very little, in fact, no time discussing that. So again, just a recap of some of the GLP-1 receptor AEs you might come across. Again, mild to moderate, dose dependent. They may increase when you go up on the dose. A very, very important point I want to make, and if you're going to take away anything tonight, it would be really addressing the diet in those first few days after injection. If you minimize fat and fiber intake, I have a large population of patients on these drugs, and very, very few have side effects. And it's not because I'm doing something special. I think it's because they're reducing the things in their diet that can also slow gastric emptying, which are fat and fiber. And again, it doesn't have to be the whole week. It can just be the first 3 days. Gallstones and pancreatitis related to gallstones have come up, but really that's the pancreatitis that comes up really is related to the gallstones. If obviously you have someone with abdominal pain and has lost a lot of weight, they're at increased risk of developing gallstones anyway. So certainly check that out. Again, pancreatitis with this medication in clinical trials, especially long-acting receptor agonists, has been very, very little. There have been some reports of visual problems, certainly in type 2 diabetes who have worsening retinopathy. Again, not common and infrequent, but certainly pay attention if you do have a patient with type 2 diabetes. And again, I talked about weight reduction and really assessing lean mass, especially after they lose 10 to 20% of their body weight, really work on and understand, send them to the dietitian to work on protein intake and also encourage resistance training so they maintain their mass. Obviously, sarcopenia is a risk in general with IBD. And obviously many of you, if not all of you, sort of know how to manage that. But just to keep in keep in mind that there really is no influence. There's not GLP-1 receptors on the thyroid. It's only been in rat studies and animal studies where they've seen thyroid C tumors, but in humans there's been none. But you should screen both for medullary thyroid cancer, personal family history, and also multiple endocrine neoplasia too. So what does the next 5 years look like for these drugs and the treatment of obesity from a medical approach? Next year, you'll see oral versions of semaglutide and the one orpho I just talked about. You're going to see that combination of an amylin GLP-1 dual agonist called CagriSema. The following year, you're going to see survodutide, that triple agonist, and then you're going to see a whole number of companies being involved and different drugs being developed, including glucagon, including a GIP antagonist, also a GLP-2 receptor agonist involved in oral versions, etc. So when we look at the future, this new area of GLP-1s, certainly there's a growing pipeline. You're seeing early detection of CKM, cardio, kidney, metabolic health, and screening that we do as obesity is the driver of that. And then you're seeing prevention of disease. This VA study came out not too long ago looking at 175 outcomes in looking at the difference in type 2 diabetes of GLP-1 receptor agonists versus other diabetes therapies. And what we're seeing in small reports already is not only the neurocognitive benefit, but a high reduction of substance and alcohol use disorders. Very interesting for the future. Again, thank you for your time, and sorry I went over, and I'll take some questions at the end.
Perfect. Thank you so much. That was a really nice overview. Some nice feedback in the chat from everybody. And we're going to turn over now, and perhaps we can type back some responses in the chat box just in the interest of time. And I'll let Dr. Feng take over with surgical options for management of IBD and obesity.
All right. I'm one of the bariatric surgeons here, and I'll be talking a little bit about how we handle IBD patients surgically. I think Dr. Atkinson already gave a really nice summary of, the increasing incidence of obesity and IBD. And it's not definitely just because both diseases are increasing statistically and there's going to be overlap. There's also probably physiologic underpinnings that are common between these two diseases. In terms of when we would consider somebody for bariatric surgery, an IBD patient for bariatric surgery, it is actually, according to the ESPEN guidelines, which I think Dr. Butch also referred to, the same indications as in the non-IBD population. So BMI of over 40 or a BMI of over 35 with obesity-related comorbidities and previous failed non-surgical weight loss attempts. I know this may not sound very earth-shattering, but as far back as 2008, the SAGE's guidelines for laparoscopic bariatric surgery actually listed Crohn's disease as a relative contraindication. So in that intervening time, what has happened, and I think it's been, a bunch of retrospective studies, certainly no prospective just yet, but high quality retrospective studies that have demonstrated efficacy as well as safety, some things that we're going to talk about later, that have really shifted the conversation and the general consensus about when we would do surgery on these patients. In terms of how we would get somebody ready, an IBD patient ready for surgery, these are some things that we definitely think about at our program, in addition to the extensive preoperative counseling that any bariatric patient would receive. We definitely have to consider the micronutrient deficiencies. These patients are already at risk for gut absorption issues and poor oral intake, perhaps related to acute disease. And the same micronutrients are going to be at risk for absorption once we alter their anatomy for metabolic surgery. So here at this program, we definitely screen everybody preoperatively with a full panel of all the relevant vitamins, the Bs, the fat-soluble ones, iron, selenium, zinc, etc. Dr. Atkinson already talked about sarcopenia, which is common in the IBD population, as well as common in the patients with obesity. And so when we put people on that liquid diet, pre-operative and post-op, we are definitely remaining very cognizant of their protein intake, as well as long-term encouraging resistance activities and things like that. And lastly, always considering, their therapy for IBD, especially if it's active or, managed disease. Are they on steroids? Are they on immunosuppression, biologics? This could probably be a whole nother talk, but these are some of the things that we think about. In terms of what choice of procedure, our preference is usually for surgeries not involving the small bowel. So that's probably a great way of just saying sleeve gastrectomy. When we alter the small bowel anatomy for a gastric bypass, some of the downstream effects could be that, they could manifest with small bowel abscesses, fistulas, etc., for those Crohn's patients. And in UC, there could be possible future need for a total proctocolectomy with a pouch. And so we really, most surgeons are probably going to want to keep that small bowel available and not put the patient also at risk for potential bacterial overgrowth. That said, there are other considerations, including the intragastric balloon, as well as endoscopic bariatric procedures. Especially endoscopic bariatric procedures potentially show some promise, but this is a very new area of study. I know of, I think, only one case report reporting on 7 patients who had endoscopic metabolic surgery, and they showed great weight loss, but the long-term data is not out there yet. In terms of safety of when we perform these procedures, so there's a number of systemic reviews and meta-analyses that have been done on this subject. All the studies that have been done are retrospective, and so compiling all of those numbers together, here's the report of one of the more recently published larger meta-analyses, but 58% of this population had Crohn's, 42% UC, and as you can see, they broke down the procedures that were performed in this population. About 58% underwent sleeve, about 30% gastric bypass, and then you did have some patients who underwent the adjustable gastric band. They defined early complications as complications within 30 days, and the rates here were reported as 15.9%, and then outside of that, they considered late at 16.9%. I know these seem quite high, but I will say in this meta-analysis, they really reported anything reportable as a complication. So anything including a mental infarct, dehydration, to a leak and bleed that was all lumped in as a complication. This meta-analysis did make note that adverse events were more common both early and late after gastric bypass than sleeve. Weight loss outcomes were very good and actually comparable to the non-IBD population. And in this study, they reported as excess weight loss at 66%. In terms of how patients did from the standpoint of their IBD disease, 45.6% decreased their medications, 11% increased, and 45.6% experienced no change. This is another meta-analysis, and I'm just putting up some of these numbers, not so, we're not going to deep dive into each of these, but all that to say, I want to call attention to the Clavien-Dindo grade 2 complications, 2 and over, as well as the mortality. As you can see, a lot of these studies reported 0%, and overall acceptable number of complications, somewhat comparable to a non-IBD population. There's one meta-analysis that performed a propensity score matched cohort. I'm sorry, that was not a meta-analysis. This is a matched cohort study of IBD patients with non-IBD patients who underwent bariatric surgery. They stratified it by patients who had UC, in patients who had Crohn's disease, and then further into patients who had sleeve versus bypass for each in UC and Crohn's disease. They found that patients who had ulcerative colitis, who underwent a Roux-en-Y gastric bypass, had a higher risk of postoperative complications than the other groups. And in terms of the Crohn's disease group, those patients tended to have higher rates of readmission after both sleeve and a bypass, and that bleeding was more common after a gastric bypass. These findings are not necessarily reproducible across multiple studies, but this was one of the larger scale studies. Again, this study echoed what some of the other ones that I've mentioned found about weight loss, and that was it was similar to between groups as well as compared to non-IBD patients. Again, another analysis just looking at specific complications. They also reported higher rates of AKI, bleeding, readmission, and again, they did tend to find that the gastric bypass patients had more postoperative complications. So once we do surgery, how is this going to affect their IBD disease? I think the data or the definitive answer for this is still yet to be found. I don't know of any prospective studies looking at this, but from compiled data, I found the following numbers. So about 11% experienced an IBD flare or an IBD-related complication. However, overall, 18.5% in the long term had improvement in their IBD, about 71.5% had no change, and about 10.7% had worsening. And lastly, I did want to mention this clinical phenomenon that's definitely been described. There are multiple case reports and case series, and that is de novo cases of IBD after bariatric surgery. The majority of these cases, and I believe there's probably something like 8 studies reporting on 16 patients, but the majority of these cases are reported as happening after gastric bypass, and a lot of the associations tend to be with Crohn's disease rather than ulcerative colitis. The mechanism right now is unknown. The patients did tend to be women, and the IBD manifested anywhere from 4 to 5 years after their bariatric surgery. So this is definitely an important question to answer. I don't necessarily think this is a reason to steer patients away from bariatric surgery if they have IBD, but it is something that we need to keep in the back of our minds and definitely needs further study. So some of the key takeaways. Indications for bariatric surgery in IBD patients, I think, should be the same as in the non-IBD population. It can definitely safely be performed in this population with good preoperative preparation, as well as consideration for those special details specific to this population. There's preference, I think, for the sleeve gastrectomy. I think it leaves the small intestine undisturbed in case of future disease manifestations, both from their IBD as well as future surgical options, and it potentially has a better safety profile. Importantly, this has been described across multiple studies. Weight loss outcomes thus far in the literature seem to be similar compared to the non-IBD population. And positive effects resulting from the metabolic surgery could potentially benefit long-term disease management. And again, in the back of our mind, we should look out for cases of de novo IBD after bariatric surgery, mostly the gastric bypass, as an area of interest. And that's all I have.
Thank you so much. Another fantastic high yield talk. And I'm loving all the activity in the chat over here. Please keep the questions coming as we move into our case discussion. If a question came through about vision changes with semaglutide, would one of our obesity experts like to comment on that?
There are case reports in non-ischemic. Actually, it's been there has been, I think, a case or so in somebody who does not have diabetes. So I think it's something that we have to look into. The link is not known. For those who have type 2 diabetes and diabetic retinopathy, reports have shown a worsening in some patients on semaglutide. But again, these case reports have more shown, obviously, an association than a causation. So it's really something that we don't know too much more about than that.
Perfect. Thank you so much. And Dr. Slyman, your slides look beautiful now. So go ahead, take us away.
All right, so if we can go to the next slide. The first case describes a 44-year-old male who presents for establishing of care. He has a history of ileocolonic inflammatory Crohn's disease that was diagnosed at age 31. Treated initially with methotrexate for 2 years, adalimumab for 3 years with achievement of endoscopic remission, but then was lost to follow-up for about 8 years without any medication. He then presented to the hospital with nausea, vomiting for 2 days, and he had been noting progressive abdominal pain over the past 4 weeks. Next slide. So talking more to him, he's an ex-smoker with no NSAID use, weighs about 350 pounds with a BMI of 51. He's pre-diabetic and had actually recently started oral semaglutide tablets with the current dosing at 7 milligrams per day. And he had so far achieved a 10-pound weight loss. Next slide. So the first few questions, I'll let Dr. Falloon guide.
Perfect. So let's start with our IBD colleagues and then move over to the obesity medicine colleagues. Dr. Braganetu, when you're seeing this patient in clinic, how do you start to try to tease out what might be medication side effect, what might be Crohn's disease?
Yeah, that's a great question. And what I typically want to think about, of course, is timing of when the medication was started. Then reminding us and just the audience that a lot of the symptoms that were described, there's abdominal pain, diarrhea, like nausea, they are kind of known side effects of the weight losing medications as well. But then really we want to also ask the patient a little bit more about severity of symptoms, progressive nature of symptoms as well. That would all also help you kind of clue you into differentiating those two. And then of course physical exam, to think if there's anything really that stands out on the physical exam from a pain standpoint. Vital signs, thinking of like true dehydration, the pattern of diarrhea, if any alarm symptoms present. And then your laboratory evaluation will also help get a sense of also elevated inflammatory markers or not, albumin that's low, if there's truly like really rapid weight loss. So those are all things that I'm thinking. For what I'm gathering here in this case, the word progressive symptoms makes me think that the symptoms are more than just mild, and they're more on the side of severe. And then the fact that the patient had to visit the hospital. So I would favor the diagnosis and just making sure this isn't a flare. So that would be my working diagnosis, with the rule out of infectious superimposed etiologies as well.
Perfect. That was a lovely nuanced answer. Anything to add, Dr. Atkinson, from your standpoint?
No, I think I agree with the assessment. I think that the first or the most important part is to rule out something different than side effects and the severity of these and the presentation. I agree with Dr. Braganito assessment, and first rule out a flare or exacerbation of the disease, and then our work around possibility of side effects.
Perfect. And Dr. Butch, you addressed this in your talk, but we're thinking about doing a colonoscopy for this gentleman. So what would your approach be to his semaglutide?
Yeah, now this is a daily semaglutide. Rybelsus is its brand name. So again, these are short-acting GLP-1 receptor agonists. Well, actually, it's semaglutide, but it's daily. But for the long-acting semaglutide, we usually stop a week prior to surgery or a procedure. If it's a daily regimen like liraglutide, Victoza, or Saxenda are the brand names, you can start the day before. There was a consensus statement in November of 2024, which included several of the surgical and anesthesia and GI professional societies, which I can send the link around, which came up with this. And the bottom line is just using common sense. If they seem, and usually the anesthesiologists could pick this up, if they seem to have some symptoms and they've done what you've told them to do in terms of stopping, some recommendations say of getting a gastric volume ultrasound to see if they have anything there. But this is an ongoing discussion, a very good one, but that's the current data.
Perfect. Thank you. Dr. Simon, do you want to take us through what happens next?
Sure thing. So we continue with the case, if we can share the screen again. And besides the workup that Dr. Braga mentioned, we get a CT enteroscopy that determines there's a 30-centimeter terminal ileum that's inflamed with changes significant for stenosis, but no pre-stenotic dilation is noted. Colonoscopy was performed. The patient was able to tolerate the bowel prep, and there was a normal colon mucosa, but severe ileal disease starting at 5 centimeters from the ileocecal valve with mild narrowing. And you can see images accordingly. Next slide. So go back to more questions.
Yeah, so now that we have a little bit more data about what's going on with this patient, Dr. Reeder, could you provide a little bit of an overview on your approach to IBD therapies in obese patients and what adjustments you make? There were some questions in the chat about JAK inhibitors specifically.
Mm-hmm. Yeah, so in principle, so the patient was before on methotrexate adalimumab combination therapy, no therapy for 8 years, and we don't really know if the patient responded to adalimumab before. So the options that exist for this patient is you could try again an anti-TNF, and there's still, for instance, infliximab, a possibility with an IV formulation. You could try an anti-IL-12/23 like ustekinumab or an anti-IL-23 like risankizumab with an IV induction, sub-Q maintenance. Or since the patient had an anti-TNF before, you could try a JAK inhibitor such as upadacitinib. The considerations in patients like this is the distribution volume of monoclonal antibodies versus small molecules. And in principle, small molecules would be preferred in patients like this if you have similar efficacy because the distribution volume is favorable. However, in a patient with this high BMI, there is a potential that their patient has already a cardiac disease. Obesity is a cardiac risk factor, which may want to make you pause on a JAK inhibitor. Patient is not a smoker, does not have a thrombotic history, it seems like. You may ask the patient for this. But my two top options, if the patient never had a clot before, doesn't smoke, and has prediabetes and high BMI, would probably be risankizumab as the first option, because it's a very safe drug, with an endoscopy 6 months after induction. And then the second choice would be a JAK inhibitor, which work really well in this scenario. But I would talk to the patient, they prefer an oral medication and then a potentially higher risk when taking it.
And then perhaps Dr. Atkinson. So this patient has active Crohn's disease now with narrowing, but without a stricture. For this patient in particular, and then in general, how do you approach prescribing obesity medications in the setting of active disease?
That's a good question and always challenging. I mean, if the symptoms were exacerbated while on medication, I would definitely consider to stop it. We know that, I mean, in general, the diet and the first 3 days after injection, well, this was oral medication, but for the injectables, the first 3 days after injection is when we have the highest concentration and more side effects. But I think if the symptoms were exacerbated, I would definitely consider to stop the medication.
Thank you. So Dr. Simon, what did we do?
So in this situation, we opted for risankizumab, as Dr. Reeder mentioned, with 600 milligrams at 0, 4, and 8 weeks as induction. Oral semaglutide was held owing to the concerns of initial obstructive symptoms and GI side effects, as Dr. Atkinson mentioned. The patient unfortunately returned to the emergency department, if you can go to the next slide, with recurrent obstructive events. A CTE now showing similar extent of disease. However, the pre-stenotic, there is dilation up to 3 centimeters in diameter. And he currently weighs about 345 pounds, and surgical intervention is being considered for the stricture.
So, Dr. Butch, I'll turn to you. We're planning for surgery. Is there anything you'd recommend in the perioperative period to try to help this patient?
Well, I would just add, I think there's multiple other options medically you can do with this patient. I think we're too hyper-focused on the GLP-1 receptor agonists in this situation. So, as I said in my talk, I would entertain several others alongside. But obviously, I think the BMI was 51, and now with where they are now, maybe in the 40s. So obviously, there's a ways to go here. So I would be calling on Dr. Feng pretty quickly and thinking about probably combination therapy, maybe perioperative pre-adjuvant therapy with an obesity drug, switching over to maybe the sleeve as Dr. Feng would decide, and then back to drugs later, depending on the BMI and other comorbidities.
Can I ask for my own education in these patients? So part of the preoperative management is optimizing the weight loss,
yeah,
medication, and then how long do you wait before you send a patient to surgery? Because, for instance, in this case, obstructive symptoms, what is how do you find the balance?
I mean, obviously, it's going to be patient dependent. This is a difficult case because of the obstruction. I mean, if you use something like phentermine, you're going to worry about constipation and obviously further exacerbating symptoms. But you can use more centrally acting drugs. You could use topiramate. You could use bupropion. And in terms of when to take them off, you could take them off a week before surgery. It's not like there's a big washout period here. But I think the one thing I'd add right there is that if you do have some effectiveness with the obesity medications, you have to understand, and that's more about sort of managing expectations of the patient, that the surgical outcome may be a little bit blunted, especially if you've lost weight prior to surgery. So that's why, because the surgery will basically include the drug effect plus the surgical effect. And when you look at sort of the total effect of the surgery, but that's a little bit about managing expectations.
Dr. Atkinson, did you have a comment as well?
No, I totally agree with what Dr. Bush was mentioning, and also optimizing the weight is more for elective surgeries where you have a period of time to work on this, on the weight loss and also nutritional status. But we are talking more in an elective surgery, so not in a case of obstruction like this case in particular.
Yeah. And I will just and say that's absolutely correct. This is sort of the management around elective surgeries, depending on the severity of how soon you're going to go to surgery. That then changes some of the dynamic with the medications.
Dr. Feng, we're referring to you. When would you think about the timing of surgical intervention from your standpoint, and any other factors that should be considered?
Yeah, I think I misunderstood the slide because I was thinking that you were going to refer this guy to one of my colorectal colleagues.
No, you're correct. We are, but we would also like him to see you.
Got it. Yeah. So after he's over his acute episode, and with or without colorectal surgery, whatever that may entail, perhaps an ileocolic resection, we would see him once he's cleared from the colorectal surgeon perspective. Typically I would clear somebody 4 to 6 weeks out, although that's obviously really aggressive. But our pre-op bariatric surgery process, IBD or not IBD, is sometimes for insurance reasons pretty time consuming. It can take a couple months. And so for better or for worse, he should be healing from surgery, in the meantime. And as Dr. Butch and Dr. Atkinson alluded to, these patients get a lot of preoperative nutritional education and psych evaluation, as all our patients do. And in terms of what I would consider for him, probably the sleeve gastrectomy. I mean, he's already had small bowel disease. We don't know what's in the future for him. And I do think it could get him, we would expect 20 to 25% total weight loss from a sleeve. And that is probably what I would estimate for him. And so that's in addition to, the anti-obesity medications that Dr. Butch was talking about.
And I'll just add to that, and I saw Florian had answered one of the questions. I think to talk about inflammation, because obviously that's a huge driver with IBD. To get something like bariatric surgery, there is a remarkable reduction in inflammation in these patients. We see benefits from psoriasis going away, Crohn's getting better, UC getting better. We see a lot of, as that fat cell shrinks, we see a huge reduction in inflammation. I spoke to the pleiotropic effects, meaning regardless of weight loss, both surgery and these drugs have an effect on inflammation. So these are non-weight dependent effects. And so I think, when that inflammation becomes a big issue, bariatric surgery like a sleeve is a really good option right here.
I agree with you. I think we will learn a lot about direct anti-inflammatory effects systemically and in the gut. And there are now combination trials being started of biologics for IBD combined with GLP-1 RAs because of that reason. I think we will learn a lot about this mechanism across diseases. And yeah, both of you highlighted it nicely in your talk. Can I ask Dr. Feng, are there instances where you do your sleeve plus the colorectal surgery at the same time in obese patients?
Wouldn't rule it out. I think it would depend on the activity of the inflammatory bowel disease. So I would say if they weren't having active disease, but it was a stricture that just needed some kind of surgical bypass, I would certainly consider that. That would most certainly corner us into doing a sleeve, for better or for worse, because we don't want to be addressing some kind of small bowel type obstruction picture concurrently with a bypass, given that if we're creating Roux-en-Y anatomy, that blind limb leading up to the remnant stomach, that could set up a situation where you have a closed loop obstruction if you have something downstream that's obstructing or could obstruct or could leak. So I wouldn't rule it out. But, in the case of if they were having an active flare, I would not. That's not something I would venture into.
Thank you.
I see that the time is ticking away here. What an engaging discussion. I have one more question for Dr. Feng because I feel like this comes up a lot, and then we'll go ahead and wrap up. But in terms of holding IBD medications around the time of bariatric surgery, is that something you recommend? Are you comfortable with us continuing on therapy? What's your approach?
I think there are a lot of medications I am not familiar with. And so there is definitely not a lot of data specific to the bariatric population. I would say we are definitely risk averse. For the sleeve, it's probably the longest staple line in general surgery. And for the bypass, it's even more complicated with a GJ anastomosis and a JJ. I would really have to probably consult my friendly neighborhood gastroenterologist and probably refer to some of my colorectal surgeons who are operating more so having to make these decisions on holding or continuing biologics. In the past, I've definitely involved them in the IBD patients that I've taken care of, because it also, I think, depends on the patient's own symptoms and how well they're being managed with or without the medication. So I don't have a blanket answer for you, but it's definitely a risk-benefit conversation.
Well, thank you so much to all of our panelists, and thank you to all our attendees as well. It was really great seeing, as I said, all that activity in the chat box. And thank you all so much for joining. We do have a number of other sessions coming up. Again, a QR code that you can scan And I see Rita just sent out the link to register for some of those sessions as well. And final plug, we do have Obesity Live that happens monthly on the first Thursday, led by Dr. Butch, who you met today. And then we also have Dr. Simone Linares and Dr. Corselis. So thank you so much to everyone again for joining.